Hi everybody, it's Michelle Andrews. Good evening to you. We're going to spend the next 20 minutes or so just reviewing some test prep questions. So as I'm getting everything in order here that I want to go over with you, these will be, just to clarify, some things that you're going to want to read up on. If you have the PALS book, definitely read up on them. If you don't have the PALS book, I put out a PALS class on YouTube. So you can, definitely rewatch that. Either way, rewatch it because that'll help you out immensely. All right, so let's jump right in. The first thing that we need to review is our respiratory illnesses. Remember I had shared with you in the PALS class that there's kind of pick-off signs. Usually they come in the form of auscultation, right? So upper airway is croup, epiglottitis, and anaphylaxis, right? So need to know that. They might have had peanut butter for the first time. They might have had peanuts in something for the first time. So, you don't know that this is going to be anaphylactic shock. So, what is that considered? An upper airway, obstruction. And what are we going to auscultate? Stridor. So, when you hear stridor, you're going to automatically be thinking upper airway. You're going to automatically be thinking, croup, epiglottitis, or anaphylaxis. Right? Increased respiratory rate with retractions. Upper airway. Croup, epiglottitis, or anaphylaxis, but upper airway. Okay, so increased respiratory rate with effort and retractions. Nasal flaring. These are all pick-off words. Stridor, retractions, nasal flaring. Upper airway. Want to read up on that. Okay, lower airway, bronchitis and asthma. What are you going to get with that when you auscultate? Well, you're going to get wheezing and prolonged expiratory phase. Wheezing and prolonged expiratory phase. Lower airway. Bronchitis, asthma. Moving on to lung tissue is pneumonia, or pending stiffening of the lung tissue, which is respiratory distress syndrome. What are we going to auscultate? Decreased air movement with grunting and crackles. Lung tissue disease, grunting and crackles. Remember, with that pneumonia, or pneumonia leading to sepsis, or you think they had pneumonia and it's been let go and it's led to sepsis, we want to give an antibiotic by the first hour that we've seen them. Antibiotic for pneumonia or sepsis. Disordered control of breathing is the easy one because it's a neurological issue. It's brain injury. It's drug overdose. It's seizures. Decreased air movement just makes sense. Decreased to absent air movement because there's poor muscle tone and shallow breathing. Disordered control of breathing, seizures, drug toxicity, or overdose, right? Okay. I wanted to review that first. The next thing I want to review is our BLS questions. that we know are going to be on the test. So let's just review BLS. We know that we're to compress to the depth of 1/3 the depth of the chest cavity of an infant or a child. But it's also equally important to recoil all the way back up so the heart can refill. That's important. It's also important to remember that we go 100 to 120 times a minute, and that if we have 2 rescuers, we'll do 15 compressions to 2 breaths, and if we have 1 rescuer, we're going to do 30 compressions to 2 breaths, okay? How long does American Heart recommend we stay off the chest? What's that max time? 10 seconds. And if you pick 10 seconds, you picked a good answer. And yes, I'm wearing glasses today. I'm out of contacts. I gotta order some. Okay. That last thing that I want you to remember about BLS is essentially the head tilt, chin lift. If they have cervical injury, we would not do a head tilt chin lift, we'd do a jaw thrust, right? Okay. So those are the things I want you to remember with BLS, and just look through to make sure. There is something else I want to go over with BLS. When they've returned, it's a post, BLS thing. Once they've returned to ROSC, right? Return of spontaneous circulation. What's that normal oxygen that we should be titrating the patient down till we get to what? 94 to 99%. You should know that. We want to titrate them down to 94 to 99%. Okay? I want you to remember those things about BLS. Now we're going to go over that formula that we reviewed in the PALS class. It was 70 plus 2 times the age in years. So 2 times the age in years was in parentheses. And remember, if they're 1 year old or less, it's just 1. Okay? Why do I want to know that formula? Because some of the questions are scenario questions, and so a lot of them are. And so they give you the blood pressure reading in there, and you kind of want to know, remember the answer to that 70 plus 2 times the age in years is kind of the on the line, right? So we want to know, should they be higher, are they lower than that? Because that's really bad. And so that's going to help you out a lot to know that formula. Also, speaking of blood pressure, know what it has in relation to compensated shock, what it has to do with compensated shock. I should have said it that way. If they're showing everything that's in the question is showing inadequate signs of perfusion, like long capillary refill time, cool extremities, but their blood pressure is normal, they're in compensated shock. That's what blood pressure has to do with shock. That's what's going to show compensated shock. So know that. Reviewing something kind of off the wall too is blood glucose, right? It's important in PALS that we check for hypoglycemia. If a child comes into triage and they're lethargic and vomiting and diarrhea, check that blood glucose. That's important. respiratory distress and respiratory failure is something you should read up on. We didn't talk a lot about it in my PALS presentation YouTube video. I'm going to tell you that respiratory distress could be like audible stridor could be a sign of respiratory distress for sure. Audible stridor could be a sign of respiratory distress. Respiratory failure would be decreased ventilation, decreased oxygenation, altered mental status, pale skin, shallow breathing. All these things combined could be a sign of respiratory distress. I think we mentioned that you give that antibiotic within by an hour upon seeing them. Now, before I go any further, I want to add a lot of the answers that American Heart Association's test will have to choose from might not be the answer that we think it should be because it's what we do in the field or it's what we do in acute care setting, but you pick the best answer. You pick the best answer. If the one you're thinking isn't there, pick the best answer. Okay? I want to tell you that because when I took the test, I often had to pick, not often, but a handful of times I had to pick the best answer. You know, I picked the right one because I picked the one closest to the best answer. Okay, now listen. Let's talk about hypovolemic shock again. You know, what are we going to see? We're going to see a loss of fluid, whether it's from frequent vomiting and diarrhea, and then, you know, they're coming in sleepy and lethargic, and oh geez, their blood pressure is low, and you know, their respiratory rate is shallow and high, and you know, they might even have a long refill, capillary refill time, and pale skin, and things like that. You know, remember I told you, you know, blood pressure is the giveaway, right? That's the giveaway that they're in, you know, shock. It's either compensated shock or shock. And remember I told you that, you know, to treat that hypovolemic shock, we do 20 milliliters per kilogram of normal saline or lactate ringers. Okay? 20 milliliters per kilogram of normal saline or lactate ringers for hypovolemic shock. Okay? All right, good. And don't forget to do your primary assessment triangle. So you evaluate, you identify, and you intervene. You reevaluate. What are we reevaluating for? Well, you just gave fluid. You want to make sure you haven't overloaded them, don't you? Yes, you do. Yes, you do. With that lung tissue disease, remember that I mentioned crackles with the lung tissue disease. Remember, crackles was the pick-off sign. Well, one of the pick-off signs with your upper airway disease was we had talked about retractions and stridor, but we didn't talk about how we would treat that upper airway obstruction. So I want to let you know that we should treat that with, and it's in my PALS video, nebulized epinephrine. How would we treat that lower airway obstruction? Wheezing, remember wheezing and prolonged expiratory phase? We would treat that with a bronchodilator, wouldn't we? Yes, we would. Don't forget, review your AVPU. Alert, voice, painful stimulus, and unresponsive. Just review, just know that is important, that you just know that. All right, so overdose. If you have an accidental or overdose or drug toxicity, you can reposition the patient, and you can, if they're unconscious, put in an oral airway. That is appropriate to do. It's also more appropriate to be bag mask ready to ventilate. So you put that in and your bag mask ready to ventilate. That's important to know. I want to talk about, I have to locate my rhythms. And I want to talk about just this rhythm right here. So we'll just put this one up nice and close and kind of far away. There's your 6-inch strip. What have you got? Sinus Brady, it says so. Don't be scared to say it. I know it says it up there, but you need to recognize Sinus Brady. And you need to know that, if they didn't have a pulse, even though that might be on the monitor, or any other rhythm on the monitor outside of VFib, obviously, or pulseless VTAC, or asystole, but any other rhythm outside of asystole, VFib, or pulseless VTAC, any rhythm on the board outside of those three without a pulse is PEA, pulseless electrical activity. So you should know that. So if I just showed you that rhythm and I told you that they don't have a pulse, you're going to tell me that that's not sinus bradycardia, that's PEA. What do you think we could do for that patient? Sure. We could definitely choose the best answer. And I'm going to tell you in this one to make sure you choose the best answer. May not be what you're wanting to see, but it's going to be the best answer. Okay? I want you to know, too, that hypoxia, and we went over this in our PALS YouTube, hypoxia is the most common reason for bradycardia in children. So you need to know that. Finishing up our test prep, I want to make sure that you can recognize this little guy here. I'm just going to kind of fold him so, What do we got here? Yes, I know. Now I'm going to bring it up closer. You don't see a clear-cut P, a clear-cut T. You see a P and a T kind of blended together. A tachycardia without a P is oftentimes SVT. There's a little rhyme for you to remember that. Tachycardia without a P is oftentimes SVT. So speaking of SVT, let's talk about this one. Oh, I see. Okay. I see what's going on. So we have SVT here. You can see that. Okay. We would give adenosine. If adenosine's not available, or if they become symptomatic, what do we do next? We do synchronized cardioversion. Synchronized cardioversion is what we would do for an SVT that is gotten more symptomatic, and we're just not going to take the time to give the adenosine, or the adenosine's not available. We would go ahead and synchronize cardiover. And finally, I want to make sure that you're familiar with this one up here. So I'm just going to go ahead and turn you around. All right, so looking at my board, I've placed a star next to the one that I want you to look at. That's ventricular fibrillation. If you look down here, you also see ventricular fibrillation that's been shocked. Now we're going to talk about ventricular fibrillation. There's fine ventricular fibrillation. There's coarse ventricular fibrillation. This is coarse. Fine would just be a lot finer energy line kind of wiggling up and down. Fine instead of coarse. Now, let's talk about ventricular fibrillation. There's two things I want to ask you. When we give a child epinephrine, we give them 0.01 milliliters per kilogram. 0.01 milliliters per kilogram when we give them epinephrine. Not 0.1, but 0.01. And when we shock them, that ventricular fibrillation has to be shocked. So we're doing CPR. And then the team leader says we want to shock at 2 joules per kilogram. Then we're going to continue CPR. We don't stop for a pulse check. We continue CPR. Then we do 4 joules per kilogram. Then we resume CPR. Then we give 0.01 milliliters per kilogram of epinephrine for ventricular fibrillation. Okay, so you needed to know that. Finally, I just want to go over, you've got a patient who's in septic shock, or you suspect they're in septic shock. For septic shock, I think we discussed this. I'm pretty sure we discussed this in the PALS YouTube. I remember saying 10 to 20 milliliters per kilogram of isotonic crystalloid over 5 to 10 minutes, right? Because it's given kind of slow. So that's, sepsis is considered cardiogenic shock. Cardiogenic shock can be you want to monitor the hemodynamics, the respiratory parameters, the arrhythmias, because you want to monitor whether or not they're leading to sepsis, drug toxicity, and direct myocardial injury. So for cardiogenic shock, you're going to want a consultation as well. But you deliver 5 to 10 milliliters per kilogram of isotonic crystalloid over 10 to 20 minutes. So it's slow. And then remember to monitor. Evaluate, identify, and intervene. So you're monitoring, right? You're reevaluating, identifying, and intervening because you're delivering it slow for a reason. We don't want any edema to develop or any crackles to develop. I hope this helped you out when you're preparing for your PALS test. Remember that the PALS program is on my YouTube channel, and that really goes in more depth. So you're welcome to watch that. If you have a question for me, just leave it in the comments. I'll be happy to respond, or you can email me at allinclusive safetytraining@gmail.com. If you are going to comment, subscribe to my channel. Also, this helps out immensely with me being able to get this information to everyone who needs it. Okay? So every subscription helps. All right? Michele Andrews signing out. Go get them, guys. Bye.